Thank you. It's really a pleasure to be here, and I've got to say one of the things I love about this meeting is how much I learn from all the other people who are participating, not only the presenters, but all of you who are posing questions. So in discussing important anatomical highlighted considerations in imaging selection, I'm going to focus on native aortic valve stenosis, although many of the comments I make will be relevant in other scenarios as well. So what are our pre-procedural imaging goals? Well, you want to make sure that the device can be safely and successfully implanted, so we're going to look at the valve that's there, the root, the ventricle, the coronary ostia. Also to inform device selection, both the size and the type, and finally to inform vascular access choice. So in other words, we want to help in avoiding vascular complications, avoiding valve dehiscence, avoiding paravalvular leaks, optimizing the hemodynamics, and avoiding coronary artery occlusion. So what are the approaches? Way back in the day, we did all the sizing, et cetera, using transthoracic echocardiography. And we learned very quickly that that was not the best way to do it. And along the way, we developed much better CT tools. And fair to say that CT right now for pre-procedural assessment is the workhorse. But there are patients in whom CT is either impossible or suboptimal, largely related to issues of use of contrast. And for those patients, we can still use intraprocedural, typically echocardiographic, done by transesophageal echocardiography. Now, in terms of vascular access, what are we looking for? Minimal diameters, tortuosity, calcium, plaque burden, and high-risk features such as dissections and complex atheroma. This is really hard to do well, for sure, without contrast CT. The CT options offer variable automation, and for this particular application, it's a non-ECG synchronized. So this is just an example of what tools we have. You can see the sort of scrolling line going up, and if you look at the bottom, you can see beautiful rendering of the short axis of the aorta at the level of the moving line. If we move to the right, this is, well, maybe that, oops, well, the one to the right, which I could not get to move, really shows the same idea. This is a stretched out view of the aorta, and in that one on the right, you could get, in fact, all the way up into the arch. So in terms of characterizing the LVOT, we're looking at the annulus, the root, the sinotubular junction, the sinus height, and the proximal ascending aorta, although the latter is less important. So one of the things we sort of learned along the way was that the annulus that we're interested in looking at for patient evaluation is not the anatomic junction between the left ventricle and the aorta. Rather, it's a virtual ring that's formed by joining the basal attachments of the aortic valve leaflets. Back in the day with transthoracic echo, we took a single diameter, and we actually did remarkably well, all things considered. But fairly early on, we learned that, in fact, that AP diameter, what we thought was sort of a maximal diameter, in fact was not. But systematically, and what we were seeing was the red line here, rather than the blue line, which is what we want, the maximum AP diameter, systematically underestimating. And that may be one of the reasons that we had a lot more paravalvular regurgitation at the time. Also, as TAVI has evolved, it challenged our assumptions about the aortic annulus. In fact, at least in the patients we see with aortic stenosis, it's rarely circular, often ovoid, and frequently, not infrequently, just quite irregular because of the deposition of calcium. So we absolutely need to use 3D approaches. This is a wonderful reference. They published as an expert consensus document and takes you nicely through how to use CT with some granularity in terms of doing these assessments. So when we get to the annulus, again, we're going to measure at the virtual ring where the cusps are attached. We measure in systole, and we measure at the time of maximum valve opening. For balloon expandable valves, we measure areas. For self-expanding valves, we focus on perimeters. And in general terms, we are sizing planned for oversizing relative to the native annulus. These are just some images showing us what the area looks like, the perimeter looks like, and the diameters. This came out of that consensus document and just takes you through very nicely the other things that you need to look at: the sinus of Valsalva height, the sinus of Valsalva diameter, when we get up to the sinotubular junction, the diameter there, and beyond that, slightly proximally, the ascending aorta. And what do we do with these numbers? Well, we go to these tables, and these are the tables for what are currently the latest generation balloon expandable valves that are most widely used. And you can see, you look at a table and it sort of tells you what size is going to work best. And these are the comparable tables for patients who were being considered for a self-expanding valve. Now let's get to the coronary arteries. So the coronary arteries we need to pay attention to. Even in patients who have no known obstructive coronary artery disease, we have to look at the height, the proximity of calcium to the ostia of the coronary arteries, the proximity of the existing valve, if there's one in place, and the length of the leaflets, although that can be tricky to measure. And so here's an example on the left. Distance here is 16.5 millimeters. We're happy with that, whereas this one on the right is under 12 millimeters. 12, 11 is kind of you got to worry about whether or not this is the right thing to do. Then we get to landing zone calcium. Landing zone including the cusps, the LVOT, and the annulus, generally done sort of subjectively, qualitatively, based on the circumferential extent, the depth of the extension inferiorly into the left ventricular outflow tract, and the thickness of the calcium projecting radially. And we use a semi-quantitative way of assessing this as none, mild, moderate, and severe. Now, why does this matter? Well, it's going to affect valve seating, potentially. Therefore, it may have an impact on paravalvular regurgitation. If there's a little spicule, you can, particularly with a balloon expandable valve, you can use that as kind of an ice pick, with the end result being annular rupture. And of course, it can influence the risk of embolization, whether it's the valve itself or whether it's debris that can go to the coronary arteries. When you can't use CT, TE is the alternate. So here are the measurements. This is kind of our multiplanar reconstruction. You have to do this with 3D. You can see here the green plane is being positioned at the level of the annulus, so we're able to measure various parameters of the annular size. We move the plane up a little bit to the sinuses of Valsalva, and here we typically will measure just diameters rather than cross-sectional area. But this is also the view that we use to determine the takeoff of the left coronary artery, which is typically lower than the right coronary artery, and therefore the one that's most likely to get us into trouble. Again, 3D transesophageal echocardiography is a wonderful tool for doing that. And then we move up to the sinotubular junction, which in this case, we see a spicule of calcium right here. So we want to make sure when we measure the diameters, we take the minimum diameters, which will pick up where the calcium is in place. So in terms of localizing calcium, here's just an example of why it matters. You can see here this is a self-expanding valve that is being deployed, and you can see calcium sort of sitting up here. And predictably, as the valve expands, it's going to have trouble expanding fully, and therefore you're going to have a gap, and then you're going to likely have some degree of paravalvular regurgitation. In this case, it was not very much, and overall the procedure was deemed to be successful. Now, what about coronary occlusion? Luckily, this happens rarely, but when it happens, it can be devastating, and by devastating can be fatal. Less than 1% in native valve procedures, more common in valve-in-valve procedures. There are a number of mechanisms. First of all, the leaflet that was there before can be pushed into the ostium of, as I said, typically the left main, or there can be debris that just kind of comes off. If either you're doing balloon inflation, we do those not so often anymore, but the debris itself can sort of occlude the orifice. And then there's a phenomenon called sinus sequestration, in which the occlusion is not at the level of the coronary ostia, but rather at the level of the sinuses. And what's happening then is you are preventing blood from getting down into the sinuses and therefore to the ostia, the coronaries. And finally, you can have obstruction by the TAVR post or from the skirt. More common in women, more common, as I've said, involving the left main, and more common in valve-in-valve versus native valve procedures. This is kind of a list of risk factors for coronary occlusion. They're I would say, the usual suspects: coronary arteries that are lower, shorter sinus of Valsalva, build bulky calcifications, and high implantation in the case of a transcatheter valve. In the case of a surgical valve, you can run into some of those problems as well, particularly if the valve is placed in a supraannular position. So this is a paper, and I'm going to draw your attention to this little corner up here, because what it sort of points out is, again, sort of the differences between ostial obstruction and sinus obstruction. So hopefully you'll take from this familiarity with the concept of sinus sequestration. At the bottom, they developed a risk prediction algorithm. And why is that important? That's important because we now have a number of approaches to leaflet laceration or cutting: basilica, unicorn, and shortcut, all of which should be considered in patients who have these high-risk features. And in fact, this is the same slide I showed you before, but highlighted here is the favorable impact of doing a basilica procedure in the patients that the algorithm identified as being at high risk for coronary artery occlusion. So we have tools. We need to identify the patients who will benefit from them. This is a patient from our group. Before the coronary laceration, et cetera, options were fully understood, fully developed. And what you can see here is an example of a patient with sinus sequestration. And what you should notice is blood flow into the left coronary artery looks pretty good, but the right coronary artery is seeing almost no blood at all. Clearly, the patient was doing poorly at this point, so the valve was taken out, and immediately there was restoration of flow, which sort of argues again that the problem wasn't an embolic debris, that it sort of plugged it, pulling the valve out wouldn't have had any impact, but was really the impact of the frame, in this case, at the sinus of Valsalva level. This is a patient who I showed you a little bit before, this sort of low left main, but I'll point out also that there was bulky calcium there as well. You get a sense for all the calcium in this short axis view from the CT. And what happened here was that there was debris that went down into the left main. This patient luckily was able to be stented successfully by an emergent PCI. You can't always do that, and again, this is a bad complication. Sometimes patients don't survive. I showed you what the angiogram looks like. This is a different patient, but the same scenario, left main occlusion. And you can see here this left ventricle is not moving at all. And when we look at the left main, you can see a little PISA even, showing you that there's obstruction to flow across the left main, explaining why the patient's doing badly. And you can see here that in this case, again, it was possible to successfully stent the left main. In summary, I think important to know, if you don't already, that imaging plays a pivotal clinical role in pre-TAVR planning. 3D imaging is essential. CT, the workhorse, echo, TEE, 3D can be a useful backup in some patients. But also important to know that imaging is also essential in research into optimal valve selection and deployment, particularly in approaches to mitigating coronary artery complications. So for all of you here who are imagers, it's important that you sort of refine your tools, particularly in this area of sinus sequestration. In the interest of time, I couldn't really go into all the little measurements, especially if you're doing a valve-in-valve procedure. They're pretty granular, but you need to learn how to do those and to be on the lookout for patients who might benefit from a procedure that lacerates or cuts one of the coronary cusps. So thank you for your attention.